Right. So the topic of evidence-based medicine, guys. So what we'll go through actually this morning, we'll see a little bit of an introduction. We'll go through a definition of what EBM is. We'll go through the 5 steps of evidence-based medicine. We'll look at something called the hierarchy of evidence, and we'll look at the common study designs. That's really what this topic is about, is the different types of research, the different study designs which you need to be aware of. Today we'll talk about one main study design which focuses on treatment, which is trials, and tomorrow we'll go through the rest. Today we'll also give some interpretive bits on how to interpret these things called p-values and confidence intervals. So that is really the agenda for today. I usually like to begin though by saying that medical practice is diverse, but it has some common tasks. So it has some common things we do as doctors, regardless of which specialty in. So you guys started with your family medicine rotation. If you go to your psychiatry rotation or your O1G and surgery rotations, which I think probably coming next, it have certain things we do as doctors, and you see doctors going to be involved in all the time. And that is really, we try to diagnose people with conditions, we try to treat people with conditions, and we try to prevent disease. So to sum up a big part of what we do as doctors, this is one of the big things we do as doctors. So the first point I usually make about evidence-based medicine is this topic, evidence-based medicine, is for everybody. You'll be able to apply the things you learn in this topic to your other fields, your other specialties. You'll be able to apply the things you learn here to psychiatry, to surgery, to ENT, cardiology, any other field. So EBM is just really a big overarching topic. I usually like to begin with a case. And this is a case, a real patient who actually saw me once. It was an obese lady, and she visited me, her GP. She has hypertension and arthritis in her spine. And she asked me, said, Doc, is there an injection there is for weight loss? So she popped this question to me, and I was like, well, not as far as I know. There is no magic injection we could give people for weight loss. But then she pulled out this article. She pulled out this article, which was in the Express the Sunday before, big center page of these people advertising a sure way to fight fat. And as you could see, the article mentions these things called HCG injections. And of course, it's promising that if people get these HCG injections, people on programs 1 and 3, they get placed on a 300 calorie per day diet. Program 2 gets 500 calories. And this thing is saying that people actually losing weight. So you get HCG injections, you get a restricted diet, people lose all kind of 30 to 40 pounds. Of course, it's expensive. You have to pay hundreds, maybe thousands of dollars over months to take this treatment. So now with this kind of information, if you as the doctor, I'm not putting you all in a hot spot, but if you are the doctor and this was your patient, what will be your response to this lady? As a doctor, what you will do? So you could feel free to type your response or thoughts in the chat. I'm interested to hear what you would say. Okay, so I've seen some people saying slide didn't switch. So you're hearing me speak, but the slide is not advancing. Is that it? Yeah? All right. Was the last slide you also? You also saw the case vignette? Introduction. Ah, so something is happening. For some strange reason, the slide is not switching. Let me see if I could fix this. How about this? If I click on the slides like this, does it work? Other scenarios. You all seen other scenarios on the screen? Yeah? All right, okay, probably. What I think I suspect I may have to do, I usually do slideshows in full presenter mode. I suspect I'll have to probably do it not in full presenter mode and just click on these slides, right? If any trouble, of course, just notify me in the chat, or Nirvana just, of course, message me like how we just did, right? So what essentially I mentioned was the case vignette, as you heard me speak about it, and I said this lady coming and asking for this injection which could make people lose weight. So HCG injections for weight loss. And my question when I paused was, as a doctor, what you would do? So what you would do for this lady? Type in the chat and let me see what it is you're doing for this lady. She said, Doc, I want these injections for weight loss. What's your thoughts? What are you thinking? No thoughts? Educate but not shut down? All right, okay. What you'll psych review? Okay, all right. Diet and exercise, all right, fair enough. You do some investigations, all right, reasonable. But what you'll think about the HCG injections? You want to give it or you don't want to give it? So that one, people seem kind of hesitant to comment on. I mean, someone is saying, Jelani is saying, I will research first. Jaren is asking, is it safe? And these are just the questions. These are the important questions which need to be asked. So, I mean, I'll tell you in medical school, when I went through medical school, no one taught me about HCG injections and weight loss. And that could be that, well, this thing probably doesn't really work. It probably doesn't really do much. But could there be some evidence that this thing works? Could there be some study that came out showing that people got HCG injections, and when they got the injections, it made them lose weight? So, of course, I've seen and I note the good responses that you all say, and I will do some research first. I'll have to educate the patient some more. I would look into the article. So that's a very good point, Daniela. What we do when we practice evidence-based medicine is we go and look for research. A patient asks a question, we ask ourselves a question, we go and we look for some research, and then we try to figure out, is this thing worth it? Is this thing really approved, as someone is saying, so that we could actually prescribe it and give it safely to our patients? So I usually use this just to start off discussion about EBM, because every week in practice, as a physician and as practicing doctors, you too all will be asked about certain treatments. Does it work? Does it make a difference? And on the other slide, I actually put up, the other slide, what I actually put was some other scenarios. So a person had a heart attack and they want to know which is the best cholesterol medicine to use. Should you take Lipitor or Crestor or similar? Which one is the best one to use? Person who have angina read about this test called a CT angiogram, and you want to know if it will give the same information as traditional angiography. And I put in this last one 2 days ago on purpose. Is COVID-19 infection spread by aerosols? What exactly caused this infection? So you may be thinking you have answers to this, but these are just some other questions that we could ask with respect to evidence-based medicine. So moving along, there's a definition for evidence-based medicine. And this definition essentially asks the question, or defines EBM as a process in which when we care for our patients, we look up information and we try to incorporate this information when we look it up to know how best to diagnose, prognose, and treat patients, right? So that's for definition. No one will ask you for a definition, but this is just a formal definition for EBM. So it's a process. It's something we continue to do throughout our medical careers. The steps of evidence-based medicine, essentially there are 5 steps. So the steps of evidence-based medicine says we usually first ask an answerable question. And how we ask this question is in the format called PICO. So PICO, P-I-C-O. So what's PICO? PICO, as is shown on the screen, is how would I describe P, a patient similar to mine? Was the intervention I'm considering? Was the main alternative to compare the intervention with, and what we're trying to accomplish. So I'll give an example as seen on the screen. In a 39-year-old man with symptoms of peptic ulcer disease, does antibiotics compared to no antibiotics lead to eradication of H. pylori? So in this example, the P is the patient with symptoms of peptic ulcer disease. The intervention we consider is antibiotics. You are aware of triple therapy. You all know antibiotics could be used to treat H. pylori infection from your 3rd year. What we're comparing it to compare to no antibiotics, and the outcome we want to see if it will get rid of this bug. There are different variations of this that we could ask. We could ask in a patient with peptic ulcer disease, does PPIs, does omeprazole compared to pantoprazole lead to resolution of epigastrine? We could ask a person with peptic ulcer disease symptoms, does triple therapy compared to quadruple therapy lead to eradication of H. pylori? But this is generally the way we ask a question, a clinical question. Once that question is about treatment, diagnosis, prognosis, or etiology, you're usually able to phrase it in the PICO format. So I want you all to remember the PICO format. The PICO format is one of the basic things in evidence-based medicine, and is actually the first step, asking the correct question. As I alluded to earlier on, today what we'll be speaking about mainly would be treatment. We'll talk about diagnosis, prognosis, and etiology tomorrow for part 2. So what's the second step in evidence-based medicine? The second step in evidence-based medicine is finding an appropriate paper, to find a research article. And I think you all probably may have an idea how to do this because you all are already on Google and you all search things up. And by extension, how we find articles, we search medical databases like PubMed. I put PubMed because that's the one that we have available for us here and we could use freely. But by extension on Google, you could also use Google Scholar. And to use Google Scholar, you just have to type the URL scholar.google.com and do your searches. And when you do your searches, it will all be medical. So the next step in evidence-based medicine is to find an appropriate article. Once you find that article, the third step says what we should try to do is we should try to appraise that article. Now, when I mean appraise the article, it means look at the article, the journal paper, critically, try to decide if the people did the study well, if they designed it properly, if the results the report is in keeping with the findings and the conclusions. Just because something is published in a journal doesn't necessarily mean that we should take it at face value and believe everything it says. So for me, when I found that out, it was disappointing news for me. When I remember finding out when things published in a journal, I always was under the impression that you could take that and run with it. It's published in a journal, it must be the truth. But that is far from the truth. It's estimated only about 1% of the medical literature is done perfect and well, the published medical literature. So it means when you see something in a journal paper, you don't necessarily have to believe it. What you should do is appraise it. At your level, at this stage, for you guys in year 4, we don't go through appraisals. We do this with our postgrad students, but definitely appraisals of the literature is things that you will be doing later on, but soon in your medical careers. The fourth step in evidence is applying the evidence, considering the patient values. So what this means is, as shown by this graphic, this was on my title slide, kind of abstract looking graphic, but I'll try to just say basically what it means. Central to this is decision making. At the end of the day, that is really what we do as physicians. I know you guys not have any practical bits for year 4 just yet, but eventually when you go on the wards or on the clinics, or even the forum posts, we'll put in this clerkship for you all, we'll be talking about treatment or common conditions. You have to make a decision. Is either going to give the patient an NSAID or not? You're either going to give the patient aspirin or not. You're going to do a surgery or not. You're going to choose to screen the patient or not screen the patient, right? I know you all had screening yesterday with Dr. Khan. So that's the decision we make. But the decision that we make considers 3 things. It considers what the best available evidence shows, tells us we should do. It considers the resources available to us, and it considers what our patients prefer. So I'll give you an example, again, related to screening. Suppose the decision we make for a 55-year-old man is that because of his age, we want to screen him for colon cancer. From your screening class, you would have learned that once you cross 50, an average risk adult should get some sort of screening for colon cancer. And suppose we made a decision we're going to screen this man with colonoscopy. So you tell him best available evidence says we should do a test. One of the tests we could do is a colonoscopy. He said, okay, doc, all right, fine. Well, tell him a little bit more about this test. And you tell him, well, to do this test, you could get it through the hospital. Appointment times might be long. To do this test privately costs nearly $5,000. That's the cost to do a colonoscopy privately. So he might say, well, doc, well, I don't have that kind of money. I don't have insurance. I can't afford that. That's way too expensive. I can't do that test. So for that reason, you may end up making the decision not to do colonoscopy for this guy. Not because the evidence says you cannot do it, but because the patient cannot afford it. And suppose you say, well, going ahead with the colonoscopy, the patient said, "Doc, I have insurance. Sure, send me fit. The insurance will pay for it." How you do this test? Tell the patient, well, you have to take a purge, essentially a bowel prep, which is a purge for about 12 hours the night before. And then when you go in to do this, they have to put a tube with a camera through the back passage into the colon. They have to sedate you, put you not to sleep in general anesthesia, but sedate you. Suppose the patient says, "Doc, that's scary. I do think I want to go through that. That test sounds kind of uncomfortable. Is there any other test we could do?" And you might say, well, there's another test. We could do something called a stool for fecal occult blood, a stool test. And you just have to pass through samples, send it to the lab, they test it, they give you a result. And the patient might say, well, doc, well, I kind of prefer that. What's the cost for that one? That one is $120 TT dollars. It's much, literally more than 10 times cheaper. So the patient, we may make the decision in that case to say, well, we're going to give you the stool test. So I just use that as an example to say how we make decisions and how evidence-based medicine fits in with all of this. Evidence-based medicine tells us what's the best available research evidence to guide us what to do, but we also have to sometimes consider what our patients prefer, and we also have to sometimes consider what resources are available to us. And the last step in evidence-based medicine is assessing what we have done. And what I mean by assessing what we have done essentially refers to this thing called the audit cycle. So the audit cycle, as shown on the screen, is really a cycle. It tells us really how we could improve the standard of care. So suppose the standard of care says all diabetics should have a HbA1c test to see how the sugar going at least twice a year. Right? That's the guidance. That's the guidelines. They tell us we should do one at least twice a year for our patients. You might say, well, I wonder if that's happening in my clinic. You could go measure 100 patients, say, hey, you had a HbA1c twice for this year, for the past year. And 20 of them might say, yeah, I had a blood test done twice, but 80 of them might say, no, I didn't get one twice for the last year. And you might ask yourself, well, why is this? Why is patients not getting the test done? Why is they not meeting what the guidelines say? And then they come up with an action plan, say we have to do something to improve this, tell all the doctors, remind them to order the test, provide point-of-care test kits so everyone could do the test in the clinic, and then you collect data again. 6 months later, after implementing your plan, you collect your data, and now you find 50% of the people had a HbA1c. You definitely improved from 20%. What you have just conducted is what we call an audit. I wouldn't say more about it because when you all go to your 5th year, to your public health rotation in senior year, you all actually get to do an audit where you collect data in the health centers or you're given data and you have to report on it. So those are the 5 steps in evidence-based medicine. I'll pause now and just ask if anyone have any questions or any questions so far about anything I mentioned so far for the morning. I'm looking at the chat. All right, if no questions, well, we'll continue, we'll move on. So in terms of the, right, let me see where I'm at. Scroll, right. So in terms of the hierarchy of evidence, the hierarchy of evidence essentially says all the studies that could be done, all the medical research could be fit into these different categories. So the hierarchy of evidence, as shown on your screen, essentially says the study that carries the greatest strength in medicine is what we call a systematic review and a meta-analysis. We won't go into that today. We'll do that tomorrow because to understand that, you need to understand what we call the randomized control trial. We'll talk about that today because that's a big one I want you all to get. So the randomized control trial is second in the hierarchy of evidence in terms of strength. Cohort studies, Alex. Cohort studies, as we'll see tomorrow, tell us about prognosis and risk factors. They tell us what risk factors make people sick. Case control studies also tell us about risk factors and disease or what could be causing a disease. Case series and case report. A case series or a case report, I'll pick a case report first. A case report is essentially one case that is written up and published in a journal. So if someone writes up a rare disease I saw a patient 2 years ago who had really bad headache, and he eventually had neuroimaging, and it showed he had a rare genetic disorder, something called VHL, von Hippel-Lindau syndrome. We haven't ever seen a case like that. The rate or mutation rate of a condition like that is 1 in 4.4 million. So I'm writing it up to publish it as a case report of von Hippel-Lindau syndrome in the English-speaking Caribbean. So case reports are good in that they highlight rare conditions, but you can't practice medicine based on them. Just because a case report said a person had a condition and they used the treatment and the treatment worked, that doesn't mean that that treatment going to work for everybody else who used that treatment who have the same condition. So case series and case reports are low in the hierarchy of evidence. The strength of evidence from them are much less than the studies above. Sometimes people publish ideas, editorials, they write something up in a journal, just like how you could read an editorial in a newspaper, researchers could publish an editorial in a journal. And just like how editorials in a newspaper could often be slanted or biased or more aligned with a person's agenda or a person's personal opinion, in the same way when people publish editorials and opinions by publishing it in a journal is often biased and it may not be very objective. And of course, lower down in the research, animal research and vitro research. Sometimes we get these emails, cure for cancer, breakthrough in cancer therapy. You get all excited, you read the thing, and what they find is some drug or some treatment inhibits cancer cells in a petri dish type setting, in the lab. Not in humans, but in labs. We generally can take that and practice medicine with it because often that research has to translate into human research before we could practice it and run with it. Again, animal research, again, I refer to the COVID-19, a current ongoing example of interest. So, of course, monkeys have been used to test the vaccines in development, and they've shown that in monkeys it elicits antibody responses. So, if in monkeys it elicits antibody responses, still not quite ready for prime time, it doesn't mean that we could take it and give it to humans. It's a step above in vitro research, but we still need to do more studies. And the studies they're doing now to test the efficacy of the vaccine to see if it could prevent the infection would be a randomized controlled trial, which is what we're going to talk about today. So essentially, we'll talk about RCTs for the rest of this topic this morning. We'll take a break or two in between. And tomorrow we'll come back and revisit these other topics: diagnostic studies, systematic reviews, cohort case controls. Part 2, all these studies, although it seems like a lot, is like probably about 10 minutes each. They are really mini topics. But I wanted to spend the rest of the EBM lecture today talking about randomized controlled trials because that is a study that tells us how to treat disease. You could think about any disease, all the diseases that exist. There are probably about 12,000 diseases according to ICD-10. That's the International Classification of Diseases. 12,000 medical conditions, imagine that. And how we know how to treat all of them is because someone at some point in time did a randomized control trial. So you need to understand how a randomized control trial works, at least basically, and understand a few calculations from them, right? So we'll go right into randomized control trials, what tells us how to treat. So essentially, this is what we'll go through, and we'll go to the steps of conducting a randomized control trial. So as seen here, there are 5 basic steps in conducting a trial. And the first step really is to pick an appropriate group of people, sampling and selection. You pick a group of people. The small circle is picked from the bigger circle. The small circle is that sample. And you pick that sample from the bigger bunch, from the study population. So that is step 1. And the important thing here is when you pick that sample, you want that sample must be representative of the population it represents, or it came from. Remember the P and PICO? If we have to do a RCT where we're looking at HCG injections compared to diet and exercise to see if it could make people lose weight, what kind of patients you might want to pick? You'd want to pick patients with obesity, people who have an increased BMI, and you'd want to pick that from a population of people with elevated BMI. So you pick a group of people, and the next thing you do is you give them, randomize them to different treatments. Now we just say one treatment was placebo and the other treatment was HCG injections. You randomize the group of people. Let's say you had 100 people, you randomize them to two groups of 50. That's a randomization, and we'll see what randomization means on the next slide. After you do that, you give them the treatments, you look at some outcome, you're going to see if people get better or not, and then you do some sort of analysis. So we look a little bit about these steps and what they entail and what they mean. Now, the word randomized controlled trial takes its name from this process, randomization. So randomization, what it is, randomization really is a mechanism by which you could create two groups randomly. I could call 100 people and if you tell me put them in two random groups of 50, that is what randomization would be, the process by which I do that if I were to select two random groups of 50 from that group of 100. And there are different ways we could do it. I could call everybody up, flip a coin, birds go in one group, numbers or tails or whatever go in the other group. I could call everyone up and tell them pick an envelope. The envelope could have either black or white. People who pick white go in one group, people who pick black go in another group. You get the idea. When you do randomization, the idea is people have a 1 in 2 probability or a chance in ending up in either group. Why is this useful? The idea in randomization, when you have your whole group of 100, when you break them up into two groups of 50, you want that those two groups of 50 are very, very identical. You want the groups to be very, very similar. And why does you want the groups to be very, very similar? You want the groups to be very, very similar so there are no differences between the groups before they get treatment. So when you give people the treatment, you're kind of really, really sure if you see an outcome, the outcome is because of the treatment and not any differences in the groups, right? So that's the idea in randomization. Randomization aims to produce two groups that are identical. So when you give treatments and you see an outcome, you're kind of thinking, all right, this treatment worked or it didn't work. The only difference in the groups was the treatment. You could understand how this might be or how it could impact a study, because let's say we were doing a study to see if HCG injections help people lose weight. We picked a group of obese people and we split them up into two groups. One group, group A, get placebo, group B, get the injections. But suppose group B had a lower BMI for some reason to begin with. Suppose the BMI of the people in group B who got the injection, suppose their BMI was 30. And suppose the BMI on the people who did not get the injection, who got placebo, suppose their BMI was 35. You could see what happened here. The people who get the injection or who have to get the injection have a lower BMI compared to the other group. So you could do this study and the outcome might be something like HCG injections work. But the HCG injection didn't really work. The people who got the injections in the first place before they got the treatment was already a little bit smaller compared to the other group. Randomization is done to avoid a scenario like this. It's done to avoid the scenario where the groups are uneven before you give them treatments. And how we know if randomization working in a trial? All trials usually have something like this. They have a table of baseline characteristics. And of course, trying to make it relevant, I picked this from a recent study that was just released, I think, and published actually last month, May 2020. As you all know, with COVID-19, there are lots of ongoing research, and this was a randomized controlled trial that tested the antiviral drug remdesivir. So you all may know it have lots of drugs that they have been testing in the past and presently ongoing to see if it will help patients with COVID-19. And this drug was given to patients. And this was what we call the table of baseline characteristics. This is a table that kind of allows you to see if the groups are very similar. And of course, this is before they receive the treatment. So this is before the remdesivir group received remdesivir. And this is before the placebo group, of course, received placebo. What you notice about the two groups, look at the age. The average age of the remdesivir group is 66. The average age of the placebo group is 64. They're very, very close. You could say they're almost similar. What we'll see in the second topic we'll discuss later on this morning, basic statistics, is you can't look at those two numbers and say that they're really different. You need something called a p-value. But just looking at it, you could see, well, the age probably may be probably similar. So the groups have similar age. If you look at the gender, you would see that 56% of the remdesivir group were men, 65% of the placebo group were men. So, I mean, again, you need a statistical test to see if that 56% is really different from the 65%. But if we go further down, we'll see that in terms of coronary artery disease, 9% of the remdesivir group had coronary artery disease, 25% had diabetes, and when we look at the placebo group, 3% of the placebo group had coronary artery disease, and 21% of them had diabetes. So you're seeing some discrepancies or unevenness in the groups, and it makes you wonder if when they did the randomization to produce these two groups, how well the randomization worked. Suppose coronary heart disease leads to worse outcomes. Suppose it makes people with COVID-19 get more sick. Then patients receiving this drug remdesivir, they're probably already set up not to recover because it have more people with coronary heart disease and more people with diabetes compared to the placebo group. And the conclusions of this study I'll share with you. This study concluded that remdesivir was no different than placebo in terms of outcomes in patients with severe COVID-19. It found no difference. So, and even a case like that, you still have to wonder, is there a reason for it? Could it be that the remdesivir group was already more sick to begin with compared to the placebo group? This is what randomization tries to circumvent and tries to avoid. And how we could tell if it's effective is by looking at this table, which is reported on all randomized control studies, the table of baseline characteristics. Now, a randomized control trial tells us which the drug we could give our patients. When I say drug, of course, a drug is not always the only treatment we want to give people. Sometimes the treatment could be a surgery or operation. Sometimes the treatment could be exercise or diet. Sometimes the treatment could be meditation or mindfulness. So when I say a treatment, or what is labeled as 2 in this arm, you randomize people to a treatment, don't always think it have to be a drug like remdesivir. There are big trials where they have taken people with borderline diabetes and they randomize them to get metformin. You all know metformin, and they randomize a group of them to get healthy eating and exercise. So the treatments or interventions in a randomized controlled trial doesn't always have to be a drug, right? Just to note. But in a randomized controlled trial, a few things could go wrong. And this slide highlights some of the biases that could occur in a randomized controlled trial. And they actually begin with C's: crossover, co-intervention, count, loss to follow-up, and one not on this slide is on the other slide, compliance. So just to touch briefly on these different biases in a RCT, you should have some basic knowledge about them because essentially these biases could invalidate the results of a randomized control trial. They could make the findings and conclusions invalid. And tomorrow, when we do EBM part 2, we'll see what that word I just used, validity or valid, means in research. Essentially, it means believable or true. But we'll see a formal definition for it. But all these could be threats to validity in a randomized controlled trial. So co-intervention, what's co-intervention? Co-intervention means a person in a randomized controlled trial getting a treatment, but they're getting something else beside which could be helping them. So a person might be in a randomized controlled trial, one group get HCG injections, the other group doesn't get any. But the people who get in the HCG injections also get in a 300-calorie diet. I don't know if you all know, but a 300-calorie diet is like borderline starvation. It's like not really eating much food. So of course, those patients going to lose weight, but they're not going to lose weight because of the HCG injection. They're going to lose weight because the other treatment they got was 300-calorie diet. So co-interventions could be something that invalidate the results of a trial. But you know what? Often when people do research, they don't report on if co-interventions were given. They're actually very sneaky sometimes with these things, and sometimes they do studies, and if people got co-interventions in the treatment group, they don't mention it because they know the authors would think, well, that is the reason why people got better, not because of the main treatment you used. So co-interventions could be a threat to bias. The other one is crossover. Crossover means you randomize a person to get a treatment or placebo. Crossover means for some reason people in the placebo group cross over to the treatment group, or people in the treatment group crossed over to the placebo group. Sometimes it's done intentionally. in part of research. So let me just say we wanted to see if which statin is better in lowering your cholesterol. You all know of the statins. We have drugs like atorvastatin and rosuvastatin. Which one is better? So we could do RCT to tell us the answer to that question. We could take a group of people with high cholesterol, give one group atorvastatin, give another group rosuvastatin, give them treatment for 3 months, measure the cholesterol levels, then take both groups off the drugs, give them a drug-free period for a month, and then switch, crossover everyone. So now the people who got atorvastatin now get in rosuvastatin and vice versa. So sometimes crossover is used as a technique in randomized controlled trials. It raises the question then how you analyze the patient. You analyze them as receiving atorvastatin, you analyze them as receiving rosuvastatin because they really received both. So it have special techniques that they do for that, which is beyond, of course, the scope of this introductory EBM class. The other one is contamination. Contamination means people got treatments, but the treatments got mixed up. So somebody taken placebo and they're supposed to get placebo, but somehow the treatments, when the researchers created it, got mixed up. And instead of the placebo, they got any treatment, or vice versa. You can understand how contamination could be a bad thing because it happens sometimes and the researchers don't even know. The researchers have no knowledge that it occurred. Compliance is probably a straightforward one you could probably relate to. Compliance and adherence simply means if the person did not or did take the treatment. You can randomize a group of people to take a certain pill and randomize a group of people to placebo. If people didn't take the pill or the treatment, then what that means, if they did not get better, you don't know if they did not get better because they took a treatment that was ineffective or if they did not take a treatment that's supposed to be effective. So compliance could make it quite difficult in a randomized controlled trial if the people don't comply with the treatment. And the last one is count or loss to follow-up. So count or loss to follow-up essentially means that people dropped out of the study. So you give a group of people a drug, you tell them, take this, come back in a week, I want to see how you're doing. After a week, half the people didn't show up. You only have the other half who did take the drug. What tends to happen in trials is the people who take the drug and who return are the ones who probably get benefit. They think, yeah, this treatment working, these people know what to do and they help me. But the people who didn't get any benefit don't come back. They say, well, this thing ain't working. I'm not bothering to go back in the study, even though they're doing it in the name of science, I'm not bothering to follow up. There's a problem there because then if you only look at the people who came back, who got relief, it's going to make the treatment look much better than it actually is. So these are some of the biases that you should just be aware of for RCTs, for randomized control trials. So the fourth step in RCT, remember we said there are 5 steps. The fourth step is when we look at outcomes. So the outcomes we looked at, I gave some examples just now when I showed you the PICO question. The outcome in that case, I used, and if this person has an ulcer that is infected with H. pylori, one of the outcomes I used was eradication of the bacteria. And you all probably know it, have tests we could do to confirm that the bacteria was eradicated. The recommendations now from the gastroenterology groups generally is if a person had confirmed H. pylori and you give them treatment, you should do some sort of confirmation to confirm eradication. You could do a breath test where you drink certain things, or you could do a stool test. So you should actually see if the bacteria is gone. And the other example I gave with that PUD example and that PICO was the person pain went away. Now, in that example, one outcome was a patient-oriented outcome and one outcome was a disease-oriented outcome. Eradication of the bacteria was a disease-oriented outcome. The epigastric pain going away was a patient-oriented outcome. Sometimes people do studies and they look at both outcomes in a randomized control trial. Sometimes people do a RCT and they look at only a disease-oriented outcome. The disadvantage of a disease-oriented outcome is that it doesn't always mean the patient could appreciate the benefit and the patient feels better. You could tell a patient here what the H. pylori is gone. Person might say, well, that sounds good. I had a bacteria, now you're saying it has gone, it has disappeared, they gave me antibiotics. That sounds good. But if the person didn't get any relief with the epigastric pain, if the person's still feeling sick, then it really probably doesn't make a difference to the patient. It turns out in the case of H. pylori, once we eradicate the bacteria and the ulcer heals, patients do get better and they do report relief. So sometimes we use disease-oriented outcomes as a proxy for patient-oriented outcomes. Keep in mind when you look at a randomized controlled trial, what is the outcome they looked at? Was it something a patient could appreciate, or is it something mainly disease focused? Were all important outcomes considered? Apart from seeing if a treatment works, we also want to know if it could produce side effects, if it could make people sick, especially if you want to test a new treatment. You're probably again relating to the COVID-19 cases going on now and the drugs. It had big talk about hydroxychloroquine, about Plaquenil, if you all were following the news or saw headlines on it, they were popping up all over the place. And can we give patients this drug, hydroxychloroquine, Plaquenil, and does it make people with COVID-19 better? That is one question, but we also want to know if it could cause adverse effects and if it can make people sick. These drugs could cause things like immunosuppression and cause agranulocytosis and cause other bad side effects. So it's one thing to see if a drug working, but it's another thing to know if it's making people ill. And sometimes you might probably wonder, well, if the drug do need two things, what we do? If it's making people better and making them ill, how we decide what to do? Usually, if the prevalence of the beneficial effect is far greater than the adverse effects, we consider giving the drug. But there might be exceptions to that. If the adverse effect is death, if it kills patients, then even if the beneficial effect outweighs the harmful effect, if the harmful effect is death, then sometimes we may not be able to prescribe or approve treatments. And there's this thing called blinding. Blinding essentially means someone doesn't know something, and blinding is used in randomized controlled trials. It could be single blind, double blind, triple blind. Single blind means the patient in the trial doesn't know what treatment they're getting. Double blind means the patient doesn't know what treatment they're getting, but the researcher who's assessing the outcome, the person who has to come and decide if the patient gets better or not, does not know what treatment the patient is getting. And triple blind means those two people don't know, plus the person doing the analysis doesn't know if what groups people belong to. All he's seeing on his computer screen is group 1 and 2. He doesn't know if group 1 is treatment or if group 2 is treatment and which one is placebo. So blinding is a big thing in a randomized controlled trial. If you notice the full word or naming of the trial when I had it up in the hierarchy of evidence, it's essentially the double-blind randomized controlled trial. So we saw what randomized is, and now we're seeing what double-blind is. Double-blind means patient don't know what they're getting. The person who's assessing the outcome doesn't know what the patient was getting. And you could probably appreciate the reason for this. If a person know what they're getting, they're probably going to expect that they're going to get benefit. If a patient knew they got placebo or inert pill, they would be like, this researcher has given me a dummy tablet. Clearly, that's not going to help. If the person assessing the outcome knew that the patient got a drug, then he might be biased in his assessment and thinking, well, I would expect this patient to get better. The person got the drug, they must get better. But we know in research, in the real world, those two instances often are not the case. When we give people pain medications and they do pain trials and they give people a placebo, a complete placebo, a sugar tablet, a salt tablet, whatever it is, they give people placebo, 30% of people report relief in pain. That's how significant the placebo effect is. You give a person a dummy pill and they're saying they're going to get relief. They say they get relief. So blinding really kind of helps to overcome the placebo effect and bias on the part of researchers. The last step in evidence-based medicine, in RCT, sorry, is really to do an analysis. And when we do an analysis, these are some of the things that we would look at. So we'll see what these abbreviations mean on the next slide. I actually spelled it out. I edited the presentation a little bit because of this. Before we go into the different ways or the different analyses we could do for a randomized control trial, what it is we probably need to look at or just mention, make word of, is this thing called intention to treat analysis. So what is intention to treat analysis? I wouldn't spend too much time on it. I just want to know that you heard the phrase and you know the word. They sometimes abbreviate it ITT analysis, intention to treat analysis, and that's a good thing. You want that done in a randomized control trial because intention to treat analysis means if a person was randomized to get a treatment, when it comes into analyzing them, you have to analyze them as though they took the treatment, even if they were non-compliant, even if they dropped out of the study, or even if they crossed over, right? So I'll say that again. Intention to treat analysis says once a person was randomized to a particular group, when it comes into analysis, you have to analyze them according to the group they were randomized to, regardless of if the person stayed in that group, took the treatment, crossed over, or dropped out of the study. And the reason that you do that is because intention to treat analysis, if anything, what it may do is underestimate the effect of a treatment, but it would never overestimate the effect of a treatment and make a treatment look more better than what it actually is. So when you do an intention to treat analysis, if the underestimated effect of a treatment still showing the treatment is better than the placebo, then you have good faith that this treatment really working. So that's just what intention to treat analysis is. I know it could be confusing to some to grasp. It's not so important at your level that you fully understand what it is. I just want to know that you heard the word and you know that is a good thing. For RCT, I want to see that people do an intention to treat analysis. That is what I want. The main things, though, I want you all to get is these abbreviations and what they mean, and we spell them out on the next slide. So these are the different measures we get from a randomized control trial. So this is how a randomized control trial could be analyzed. Now, what I would say is this is one of the ways to analyze the result of a randomized control trial. And what it essentially says, as shown on the slide, is people going to get the intervention. Some of them going to have the outcome. Some of them not going to have the outcome, PNR. People going to get control, placebo. Some of them going to experience the outcome. Some of them not going to experience the outcome, Q and S. The outcome in this case is something bad. So yes, the outcome means the bad thing occurred. So if we are looking at if patients survived or died, the outcome would be death, and yes refers to the person dying. So we usually report on the outcome we're trying to prevent. We usually report on the bad thing. Because if you notice, all the words on the slide is relative risk reduction, and absolute risk reduction. They all have in common the word risk. And risk is the chance of something bad happening. If I ask you what was the risk in a population who got COVID-19 out in Trinidad, 116 people who got it, what was the risk? You will tell me, well, the risk was 8 people died. 8 people out of 116 people with confirmed COVID in Trinidad passed away. So we report on the death rate. So for this calculation, to understand this table, the outcome, yes, refers to what we're trying to prevent. In this example I just gave, it would be death. So what's this thing called the EER? The EER is probably, no, it's not stated on this slide, but I suppose you can make a note of it. The EER is the experimental event rate. Essentially is the prevalence rate or the incidence rate, I should say, in the intervention. And the CER is the control event rate. Essentially, this is the incidence rates in the control group. So note how EER is calculated, P over P plus R. So let me just say if I told you P was 1, and R was 9, let me just say 10 people got an intervention and 1 of them died, then you'll say the experimental event rate is 10. Similarly here in the control, let me just say Q was 7 and S was 3. 7 people out of 10 people died, so the control event rate was 70%. So 70% in the controls died and 10% in the experimental, the intervention group died. And just based on that, you're already kind of thinking, well, if more people died in the control group, then this intervention seems as though it's working. But in randomized control trials, we have some measures that try to give it a little bit objectively. Relative risk is the main one, or one of the main ones we use. And relative risk is simply one event rate divided by the other. It's the experimental event rate divided by the control event rate, one over the other. Just now we worked out what? 10% and 70%. So if we say 10% divided by 70%, 1 over 7, whatever that works out as, that is the relative risk. What's the absolute risk reduction? The absolute risk reduction now is the control event rate minus the experimental event rate. So just now here we got 70%, here we got 10%. The absolute risk reduction would be 70% minus 10%, which is 60%. So note the difference between the two. One is relative, one divided by the other, and one is absolute, one minus the other. So there are different ways of looking at the same data. We'll see how we interpret them in a bit just now, but just understand how they are calculated. And the other measure that we calculate or work out is this thing called the relative risk reduction. The relative risk reduction is the difference over the control event rate. Out of the baseline risk, out of the people who don't get any treatment, how much the rate of them dying, how much is this difference expressed as a fraction out of that? It's harder for me to spell out relative risk reduction for you in words, but how it's calculated is the absolute risk reduction. If you notice, CR minus the ER is the numerator here in the relative risk reduction. It's the absolute risk reduction divided by the control event rate. And this thing called NNT, as we'll see, I have it defined 2 slides or 3 slides down. It's what we call the numbers needed to treat. The numbers needed to treat is 1 over the absolute risk reduction. So if we got here the absolute risk reduction as 60%, the numbers needed to treat is 1 over 60%, which is what? 1 over 60% is 1 point something, 1.6 or something like that. So what this means, we could round that 1.6 to 2. This means we have to treat 2 people with this intervention to prevent 1 person from meeting the outcome, from dying. I'll just switch to that numbers needed to treat slide. And this is what NNT means. It means the number of people we need to treat with the intervention to prevent or promote 1 additional outcome. So if in this example here, what I said, we got the NNT of being 2, right? We usually round it to the nearest number. It means for every 2 people I treat with this intervention, we're going to stop 1 person from dying. So these are just some different measures. I know this could be confusing at first when you look at it, the calculations, the numbers. So that's why I talk you through it. You could go through after, look at it, listen to it in terms of the recorded presentation. But we have some examples to help you with it, both in the presentation now that we're going through today, as well as in the forums that we'll post that I'll mention by the end of this lecture. So look at this example. In this example, we see 50 people got an intervention and 50 people got a control. Now, what's the experimental event rate? 20 over 50, which is 40%. So this is 40% of people that died who got the intervention. Remember what we reported is the death rate. So 40% of people died in the intervention. In the control, there were 50 people, 45 of them died. So what's the control event rate? 45 out of 50, which is 90%. So you're already thinking, well, in this case, it have more people dying in the controls than the intervention. It seems as though this treatment probably working. But let's look at the measures. The relative risk here is 40 over 90, which is 0.4. That's the relative risk. The absolute risk reduction is the difference. 90 minus 40 is 50%. That's the absolute risk reduction. The relative risk reduction is the absolute risk reduction, which is 50% over the control event rate, 90%, which is 0.56. And here we worked out the numbers needed to treat. How we get to 1 divided by the absolute risk reduction, 1 divided by 50%, which is 2. So this means, again, in this case, for every 2 people we treated with this intervention, we'll stop 1 person from dying. So what do these measures actually mean? Looking at the relative risk, if the event rate here, the control event rate here, and the experimental event rate here were the same exact numbers, what would be the relative risk? If the experimental event rate here and the control event rate here were the same exact numbers, what would be the relative risk? Let me see if you all could figure this one out or type it in the chat. Someone thinks 1 question mark. Does anyone else agree? 1, yeah, definitely. Most correct. So you guys figured it out. If the control event rate and experimental event rate is equal, you're going to get a relative risk of 1. So a relative risk of 1 means that both groups were the same. A relative risk of 1 means there were no differences between the treatment and the control. In other words, the control or the treatment is as good as the control, no difference. So guys, keep that in mind. Keep in mind that a relative risk of 1 means no differences between the groups. Once you understand that basic concept, because we arrived at the relative risk by dividing one event rate by the other, if something divided by something is 1, then it means both numbers were the same. And if both numbers were the same, it means both groups were the same. And if we're talking about here the outcome here, we're saying the outcome of that was the same in both groups. If both event rates were the same, through that same reasoning, the absolute risk reduction would be what? If the absolute risk reduction means the CER and the EER was the same, what would be the absolute risk reduction? You will figure it out for relative risk. Is really not a trick question to figure it out for absolute risk reduction. Something minus something, if those two somethings is the same, would be 0, right? I see people have much more conviction in this one. That is good. It means you are still waking and you haven't fallen asleep, which is a good sign. Thank you. So essentially, absolute risk reduction as 0 or relative risk of 1 means the intervention and the treatment and the control in a study is no difference. I kind of spell it out here on the slide, but what would it mean then if the relative risk was less than 1 or if it was more than 1? It depends on what the outcome is. In this case, the relative risk was less than 1 as a fraction, because this number here, the ER, was less than the CER. If the experimental event rate is less than the control event rate, it means you'll get a relative risk of a fraction. It'll be less than 1. So anytime you see a relative risk of a fraction, if the outcome was for something bad, it means there is less of that bad thing in the intervention group compared to the control group. It makes you think, well, the treatment probably working. If the relative risk was more than 1, if the relative risk, let me just say in this example, suppose I told you the relative risk was 1.5, what that would mean? That would actually mean that the intervention had a death rate 1.5 times that of the control rate. And now that would make you think, well, this intervention actually killing people, it's making people more sick. We shouldn't give that drug. So if the relative risk is more than 1 and the intervention and the outcome is for something bad, you're thinking the treatment is harmful. If the relative risk is less than 1 and the outcome is something bad, you're thinking the treatment is working, it's helping people. And if the relative risk is 1, it means no difference. The treatment as good as control, there is no difference. I'll go to the chat and just pause and ask if you all grasp that basic concept. And if anyone confused by it, please say if you're unsure or didn't get that basic explanation. I spend time going through it because I really want you to understand it in terms of what it means. Once you understand how these things, relative risk, absolute risk reduction, these things are calculated, once you understand how it's calculated, I think you're kind of understand. Okay, so thanks, Julie. Julie says she thinks it seems good. It'll become much clearer because what it is we're going to do now, I believe, is I'm going to give you an example to work out, everyone here. So this is the example here, right? So you could probably jot this down because I would have to advance the slide for the results unless you all have the presentation opened up on your device at home or wherever you're at, and you could look at it as well. But you could probably jot this down. So we want to see if this drug works, recombinant tissue plasminogen activator. You all know what that is from your pharmacology days in year 3, clot busters or things that dissolve a clot, right? So we want to know if it really saves more lives in people with acute ischemic stroke. So, of course, the studies that, yes, it does, to tell you the evidence, yes, the evidence confirms that it does save lives in people with acute ischemic stroke and prevent disability. Of course, once people could get to the hospital and get the treatment within like 4.5 hours from the onset of symptoms. Difficult, hardly or rarely happens in our setting because people often don't get to the hospital, get the CT scan, get the treatment in time. But of course, the study that would have proved the effectiveness of this was a randomized control trial. This, of course, is fictitious just for the example for you all to work out. So RCT was done, 400 people. 200 people got RTPA, that was group A. 200 people got placebo. Right, so 200 people got RTPA and 200 people got placebo. So group A was intervention and group B was control. I suppose that is really all you need from this slide to write on. Group A, intervention, group B, control, right? 200 people in each group. And these were the results. In group A, 40 people died. And in group B, 50 people died. So what it is, we'll take a little break now to do, right? We'll take a little 10-minute break now, everyone. I want you all to work this out. And what it is you're working out, essentially working out this table. You're already filling in the numbers in this table using this data, right? So remember, group A was what? Group A was the intervention, and group B was the control. 200 people in each group. In group A, 40 people died, while in group B, 50 people died. So what it is I want you all to do is on your own, you could do it on a piece of paper or whatever, however easy it is for you all to work out on your own. But you all to construct the 2 by 2 table, which is really this table, right? With all the calculations. You could refer to it if you have the PowerPoint presentation open up on your device. And I want you all to work out all these things. I want you to work out the control event rate, the experimental event rate, the relative risk reduction, the absolute risk reduction, and the numbers needed to treat. Right, so we'll take a 10-minute break now. I'll come off, I'll mute my mic. And in 10 minutes time, now it's 10:08, so 20 past 10, I'll come back on and we'll discuss the answers. You all will tell me what answers you'll get and we'll discuss it. And after we do this, we just have to talk about two things in terms of analysis and interpretation of outcomes. We have to talk about p-values and confidence intervals after we come back from this, and then that would wrap up EBM part 1, the first lecture we have for today. So I'll just ask if you all have any questions at this point. Before I mute my mic, if you all have any questions, post it in the chat, or you could feel free to unmute your mic and speak. If no questions, and you all could probably go ahead and see if you could work this one out. I'll leave the slide up on the screen. All right, so I'll be with you guys in 10 minutes time. Okay, guys, I am back. How was this calculation? What you all got as your answers? So who worked out a relative risk? You all were able to work out your relative risk? What relative risk you all got for this data? You could post it in the chat. Don't be afraid. Who would be the brave soul to post a relative risk? All right, I've seen lots of people posting a relative risk of zero 0.8. So I suppose consensus means it should be correct, right? And it is correct. So yes, well done, guys. 0 0.8 is correct. And you would have gotten a relative risk of 0.8 because the control event rate was 25% and the experimental event rate was 20%, right? So you got 0 0.8 because you say 20 over 25. So a relative risk of 0.8. So looking at that relative risk of 0.8, in this case, the outcome was something good or bad. It was something bad. We're looking at debt. So a relative risk of 0.8 in this instance would mean what? The treatment RTPA was better than placebo, or placebo was better than the treatment, or there was no difference? Which one do you think? Better. Shari saying it's better. Yeah. So that means the RTPA was better. Yes, most correct. So because the relative risk was a fraction, it means the event rate of death in the treatment was less than that of placebo. So obviously you will get a relative risk that is a fraction. How about the absolute risk reduction? The absolute risk reduction in this case is simply the difference between the two groups. So what's the difference between the control event rate and experimental event rate? What absolute risk reduction you got? Right? Javier is saying 0.05. Giovanna is saying the same thing. Yes, 0.05. And 0.05, I hope you all know, is the same as 5%, right? Right? Yeah, most people got that. That's right, Sarita. 5% is 0.05. But don't tell me 5% is the same as 5, right? Even my postgrad students sometimes tell me that. They're working out something and they tell me 5 is the same as 5%. And I tell them, no, I have to send you all back to primary school. Because 5 is 5. 5% is 0.05, as Sarita correctly highlighted in the chat. So most correct. And based on that ARR, the NNT is what? The NNT is the numbers needed to treat. So it's 1 divided by the absolute risk reduction, 1 divided by 5%. Makisa and Travis, yes, everyone's saying 20. So most correct, guys, right? So I think you all got this calculation, which is really, really good. So what this means in words, this means for every 20 people we treat with RTPA, we'll stop one person from dying. That is what it means. So the NNT is better if it's a big number or if it's a small number. NNT is better when it's a small number because when you want to treat a few people to stop one person from getting sick, you don't want to treat 1,000 people to stop one person from getting sick. It depends on what that getting sick means. If the outcome is death, you may be willing to. So the answer to the question, what is considered a good NNT, is not something set in stone. I can't tell you all a good NNT is between 5 and 20, or a good NNT is less than 100, or it depends on what the outcome is, and it depends on what the intervention is. Again, you all did screening, so I could relate to a screening example when I say the numbers needed to treat or the numbers needed to screen for breast cancer with mammograms, to do our mammograms, is about, depending on the age group, between 500 and 1,000. So you need to do about 500 to 1,000 women, send them for mammograms over about 7 years. You need to do that for about 500 to 1,000 women before you could prevent one lady from dying from breast cancer. That's the impact mammography has as a screening tool for prevention of breast cancer. So you might think, well, why does we have to do so much scans to just stop one person from dying? Is it worth it? Well, you could argue that probably it is worth it because what you're trying to prevent is death. But I wouldn't go into too much detail in terms of the NNT. They consider other things like cost effectiveness and other aspects of treatment before they decide and agree. So I think you all got the calculations. And just for the record, the relative risk reduction that you all would have gotten, that was the other thing we're supposed to calculate, the last measure. Well, what was the relative risk reduction that you all got? Relative risk reduction, right? Yeah, you guys saying 0.2, yeah? 0.2 or, Sarita, I know you were telling me 0.2 is the same as what? 20%, right? That's right. So 0.2 or 20%, most correct. So That was the relative risk reduction. Now, what it is I would show on the next slide, so we leave in the calculations for now. What it is I would show on the next slide is essentially two hypothetical studies. So these are two hypothetical studies that are unrelated to the example we just worked out, right? So it is not related in any way to the example we just worked out. These are two separate randomized controlled trials, or RCT-A and RCT-B. Looking at it, if you look at the control and experimental event rates, you would see both of them produce the same relative risk. Both of them produce the same relative risk of 50%. Relative risk reduction, sorry. Both of them produce the same relative risk reduction of 50%. But look at the NNTs for the groups. The NNT is 4 for study A, and for study B, the NNT is 10,000. Which study you would prefer? Which study is the better study? A, most correct, right? Most correct, definitely. Study A is the better study, right? Annalise, I see she posted a question. I don't understand why there's a row with yes minus that and a row with no. All right, Annalise. So what essentially we were saying then is we were saying it wasn't yes minus that, it was yes dash. So if I had to edit this slide, yes means yes, the person died, right? So it wasn't yes minus that. So my bad if that's how it came across. No means the person no. I could put dash did not die or no dash the person survived, right? So it's just the outcome. One is the person lived and one is the person died. I just was trying to highlight that yes referred to death, the person dying. I don't know if that clears us up, Annalise. Yeah, right. Okay, good, great, excellent. So right, so moving on. So to wrap up this bit about RCTs, two big things again I want you all to get. The main thing I want you all to get at this level as medical students is interpretation. So what I usually try to do is use examples and try to give explanations to make sure you all get interpretation right. Because what I expect you all to get out of this lecture really is to be able to interpret medical literature. And so far you all have been doing great with the calculations. You have been able to work out the calculations and understand and interpret them in terms of what they mean. So two things again we just have to discuss to wrap up RCTs and EBM part 1 for this morning. One of them is confidence intervals and the other is p-values. So the first one we'll talk about is this thing called a confidence interval. So what's this thing called a confidence interval? Confidence interval, as the word suggests, is an interval. An interval is a range of values. And by convention, what we use in the biomedical literature, in medicine and in many other sciences apart from medicine, we use 95% confidence intervals. What does 95% confidence intervals mean? 95% confidence intervals mean that you have a range of values, and the chance that that range of value include the real value is 95%. And I try to give a somewhat kind of silly example here relating to you guys, Group F, class of 2022. I could say I'm not sure what the average age of Group F students are. I could say I'm not are doubtful. Probably it's close to 20, 21. I know that is roughly the average age of most of you guys. But suppose I said the 95% confidence interval for the age or the average age of Group F students is 20 to 30 years. I provided an interval, 20 to 30 years, 20, 21, 22, 23, all the way to 30. That's the interval. And what I'm saying by calling it a 95% confidence interval, I'm saying I'm 95% sure most of the people in the class, the age ranges lie within that group. That is really what a confidence interval says. A confidence interval says we don't know the exact value, but we're 95% sure the exact value lies within this range. Right? So once you could get that concept of a confidence interval, you'll be able to kind of understand it and interpret it and apply it to what it is we're talking about today. So the key thing with a confidence interval is to look at your interval and ask yourself, does this interval include a value that I am interested in? So if we were thinking, if you thought before, well, yes, I think the average age of Group F students is 21 years. And I tell you, well, I'm not sure, but I'm 95% sure it lies within the range 20 to 30. You would tell me, yes, I'm correct. Suppose I told you, though, that the 95% confidence interval for the average age of Group F students was let me just say, make up a kind of off interval, 40 to 50 years, then you would tell me, no, that range doesn't include the real value or the true value. You would say that confidence interval, no, it's inaccurate. So that kind of concept is probably the easiest way I could bring it across, but the application comes in how we interpret it. And this is the interpretation. If we're looking at things like relative risk, right? Relative risk we just worked out, and we saw that a relative risk of 1 means there is no difference between the groups. What I would also say, as I have it on the slide here, is other measures that we would see that we use a lot in medicine is odds ratio and hazard ratio. Those are the ones you see commonly being reported in the medical literature. I would probably touch on odds ratios tomorrow in terms of how they are calculated, but it's not so much for you to understand how they are calculated. If you look at the words in themselves, you would see that they are ratios. So our odds ratio is a ratio of our odds in one group compared to our odds in another group. Similarly, a hazard ratio is a ratio of what we call something called hazards in one group compared to another. So in a sense, both of these measures are kind of like relative risk, because we just saw that relative risk itself is a ratio. Relative risk is the ratio of the control event rate to the experimental event rate. And anytime a ratio for something is 1, what it means the 2 bits that made up that ratio were the same. So if you ever see a relative risk, or odds ratio, or hazard ratio 1, it means there is no significant association. It means both groups are the same, right? So that's the first bit I wanted to get. What would happen though if the confidence interval does not include the value 1? If the confidence interval excludes the value 1, then what you should do next is look at the actual value of the relative risk, or the odds ratio, or the hazard ratio. In the example you all just worked out, the relative risk you all got was 0.8, right? 0.8 would suggest in this case 0.8 times or 0.8 times risk of death means a person have a less risk of death. If the confidence interval for relative risk excludes 1, then you're thinking, hey, there is a significant association, right? And if that value is less than 1, you're thinking, well, it's a positive association, right? Now, if the value is more than 1, it's a positive association. So if we got a relative risk of, let me just say 1.5, then that means the more treatment you have, the more people are going to get sick, right? So in short, a relative risk odds ratio or hazard ratio are less than 1 means a risk factor or a treatment is protective. And a relative risk odds ratio or hazard ratio of more than 1 means a factor or treatment or whatever we're looking at is a positive association. The more of that factor you have, the more of the outcome you're going to see. So of course, we have to look at an example for it to not be so abstract, right? So this is the example. You're probably familiar with the drug tamsulosin from your pharmacology days. It's a drug that's classically used to treat benign prostate enlargement in men. It's an alpha blocker, right? A selective alpha blocker, if you remember your pharmacology. But they have also shown you could use this drug to help people pass out kidney stones, especially if the kidney stone is within the ureter, right? So the ureter between the kidney and the bladder. If you have a kidney stone there and the size is less than 8 millimeters, we give patients these drugs to help them pass the stone out. I actually wrote Flomax, which is tamsulosin, for a lady with kidney stones, and the pharmacist called me and said, "Doc, you know you wrote Flomax for a lady?" I was like, "Yes, I know I wrote Flomax for a lady." He said, "You sure you want her to get Flomax? You sure it wasn't Flamma MX or something else?" I said, "No, I'm very sure it's Flomax." I didn't give it to the lady because I know the lady doesn't have a prostate. I give it to the lady because she has a kidney stone in her ureter. So we could use tamsulosin to treat patients if they have a kidney stone trapped in the ureter. This, of course, we know because a randomized controlled trial was done years ago, which proved that it was efficacious. And this is actually the result of one of those trials. So if you look at this, people in the tamsulosin group had a relative risk of 2.93, but it's a relative risk of what? It's not a relative risk of death. It's not a relative risk of getting sick. It's a relative risk of what was the outcome? Stone expulsion. So in this case, the relative risk of stone expulsion was almost 3, 2.93. Look at the confidence interval. The confidence interval is 1.6 to 6.7. All you have to ask yourself, this is a confidence interval for relative risk? Yes, right? To go back to the other slide, it's a confidence interval for relative risk. So what you have to decide is, does the range or does the interval include the value 1? Looking at this range, 1.6 to 6.7, does this include the value 1? No, it does not, right? The range 1.6 to 1.7, as I say, is an interval. So it's 1.6, 1.7, 1.8. You keep counting until you reach 6.7. Sorry. So that range does not include the value 1. So how we interpret it? Going back to the explanation here, what this means is it excludes 1, so it's significant. The confidence interval is more than 1, the relative risk. So in that case, there's a positive association, meaning people who get tamsulosin are more likely to pass out a stone. Is it significant? Yes, it is significant. It's significant because the confidence interval excludes the value 1, right? So in this case, we could say tamsulosin significantly increased the risk of people passing a stone out. And we would say, yes, we'd go ahead and give the drug. I would pause here because I know sometimes this tends to confuse people, and ask if you all have any questions about this. Post it in the chat. All right, so I'm not seeing any questions, so that means everyone got it, so either everyone's absolutely confused, but what it means in this case is going to give the drug, right? I'll give you all a next example. Look at this example. This was actually from the remdesivir trial, the one that I showed the baseline characteristics for. Remember the trial where they actually gave people remdesivir to see if it would help people with COVID-19? What they reported on was a hazards ratio. And what we said hazards ratio, odds ratio, relative risk are all interpreted the same. Based on this hazard ratio presented 1.23 and the 95% confidence interval of 0.87 to 1.75, tell me what's the interpretation. Does remdesivir work compared to placebo? Tell me what you all think. Is it significant or not significant? You all could type this one in the chat. Remember what you have to do. Just look at the confidence interval. Ask yourself, does the range include the value 1? Does 0.7 to 1.75 include the value 1? Jade is saying not significant. All right, Jade, why is it not significant? Jade doesn't want to justify the answer. It is the correct answer, but I just want to make sure you all understand why. Not a value of 1, correct? So the range 0.87 to 1.75 includes the value 1, right? It includes the value 1. So that means if we were to repeat this study 100 times, I'll spell it out in words what it means. If we were to repeat this study 100 times, which nobody probably going to do, we're going to get a hazard ratio. Sometimes we'll get a hazard ratio of 0.9. Sometimes we'll get a hazard ratio of 1.2. Sometimes we'll get a hazard ratio of 1. 95 out of 100 times, we'll get a hazard ratio within that range. But that range includes the value 1. So if it includes the value 1, what we're really saying is there's a 95% chance that in this case, the hazards ratio could be 1. And if there's a 95% chance the hazard ratio could be 1, we said a hazard ratio of 1, or odds ratio of 1, or relative risk of 1 means there is no difference between the groups. So in this case, this was the statistical proof that remdesivir was not better than placebo. And that's how we're able to figure it out. Any confusion about that interpretation? All right, so Jade is asking a value of 1 is bad. It's not necessarily if it's good or bad. what I would say is not good or bad, is simply, is it significant or not? So in this case, the hazard ratio includes the value 1. So it means remdesivir had the same outcomes as people who got placebo. Now, how you interpret that is up to how you interpret that for you to say good or bad. You could say, well, not bad because I was kind of hoping the drug worked and I could give people it so they wouldn't die from COVID-19. So in that sense, you could probably say it's bad. It depends on the study then. Most correct, Jade. It depends on the study and it depends on the outcome and it depends on the treatment, right? Most correct. You're welcome. So it's not not so much good or bad as the interpretation. What the interpretation tells us is both groups were very similar. Now, when we test treatments, we would hope that the treatment is better than placebo, but often that is not the case. Sometimes the treatment is as good as placebo, meaning it doesn't really make much of a difference, right? So the interpretation is really what I want you all to get out of this whole thing, interpretation. So if you note the difference between this confidence interval, 0.87 to 1.75, that includes the value 1. What I'll do is give an example just to make sure you all get it. And I probably would try to do this as a poll. Let me see how I could do a poll. I think I should be able to do a poll for this thing. All right, so let me see. I'll just so I'm doing up a poll. And you will just say yes or no. I'm asking if it is statistically significant, right? Is this significant? Relative risk 6.5, 85% CI 2.3 to 9.7. All right, so I'm posting a poll and I'm asking, is this significant? Right? So relative risk 6.5, 95% confidence interval 2.3 to 9.7. You are likely answering the question, is this significant? Yes or no. If it's significant, you say yes. If it's not significant, you say no. All right, so for 3 responses, people kind of slow on this one. I've seen the speed picking up now. Right. All right, twice as many people saying yes as no. It seems consensus, so popular vote would win. All right. So in this case, popular vote or consensus wins because the answer is yes, this is significant. So this is significant because the confidence interval 2.3 to 9.7 excludes the value 1. Right? So for those of you who said no, it is actually significant. We can't say it's not significant because the confidence interval excludes the value 1. Right? Let's do another one. All right, so check this one out. Hazard ratio, spelled hazard wrong, is HAZARD. The hazard ratio is 1.6. The 95% confidence interval is 0.1 to 5.2. Is this significant? Right, if you think it's significant, you click yes. If you think it's not significant, you click no. All right, so again, I see consensus seems to win out by this one. So far, 23 people have said, if I show the responses, 23 people, 25 people have said no, 5 people have said yes, and the people who have said no, of course, is correct. But understand the reason why. It is significant. It is not significant, sorry, the answer is no, because the confidence interval 0.1 to 5.2 includes the value 1. Now, I think some people get kind of confused when we say includes the value 1, what it means. Remember that range is an interval. It's 0.1 counting all the way to 5.2. So if I were to count in 0.1 increments, 0.1, 0.2, 0.3, 0.4, if I keep going, I would meet 1, then 1.1, 1.2, 1.3 until 5.2. So that means in this case, there is a high probability that the hazards ratio is 1 because the range includes the value 1. So the correct answer is no, it is not significant because the range includes the value 1. We'll do one more, right, just to make sure the persons who haven't quite grasped it able to, because I know you only learn this thing by repetition, so let's do one more. Is this significant? Right. Look at this one. So we have a COVID vaccine and we found it reduced the risk of infection. It reduced the odds of infection. We reported it as an odds ratio. So we said the odds ratio for COVID-19 vaccine and infections with COVID was 0.3. 95% confidence interval, 0.1 to 0.7. So what we want is that range significant? Is it significant? That's all you want to know. Right. So again, general consensus seems to win out this one. I'll show the responses. So 21 people said, yes, it is significant. 5 people said no. So in this case, yes, it is significant. And the reason it's significant is because the confidence interval, 0.1 to 0.7, excludes the value 1. It does not include the value 1. Right? So because it does not include the value 1, we say it is significant. So in a nutshell, odds ratio, hazard ratio, relative risk, if the confidence interval includes the value 1, no significance at all. If the confidence interval does not include the value 1 or it excludes the value 1, like this case, it is statistically significant. What it would mean though, if I told you the odds ratio or the relative risk or the hazard ratio in this case was 0.3, what that mean? It's less than 1. So that would mean, right? I'm going to end this stop polling, right? What that would mean? That would actually mean that there's a 0.3 odds of people getting the disease in those who had the vaccine. Now, if there's a 0.3 odds or 0.3 relative risk or whatever, however you want to make it, we actually saying the risk is less. So generally, anytime you see a hazard ratio, odds ratio, or relative risk that is significant, your first task is to determine is it significant. Your next task then is to interpret it in terms of what it means. And that example I gave just now with the vaccine, the hazard ratio, the odds ratio of 0.3 would mean people who get the vaccine is an inverse relationship. They're actually getting less of the disease. In other words, the vaccine is protective. Right, so I know this could be a bit confusing. This is why I went through the polls. If anyone is confused, please post in the chat. I know it takes a bit of time and practice to get it to grasp this concept of interpretation of confidence intervals for relative risk. This is usually one of the things that over the years in teaching these topics, I know students kind of mix up, which is why, I try to give lots of examples in my presentation, do polls, and it will come out in the forums too as well. So is there any questions? Don't be afraid to say, you might think, well, lots of my colleagues get this, but I don't get this thing. Don't be afraid to say, If you're uncertain, you could still post or raise the question. All right, so if repetition helps, okay, thank you, Julie. Repetition does help, which is why I believe that is one of the things we use to emphasize a point to make sure people understand things, right? But even if people still confused, you all could actually contact me through Moodle, or you all could email me anytime, all right? I'll share my email address, my email address, so you all could reach out to me anytime on Moodle or online at any point in time if you're unsure about anything that I teach or anything in general about family medicine, all right? So moving along, the last thing we have to say this morning is about, do I have something else? Do I have something else? Ah, yes, this is an example I had. You see, I just try to put so much examples. This is one last one I think I had for, before we go on to p-values. Yeah, this is one I had for some research I did actually with my year 2 medical students. These would be guys from your class. And it was really looking at predictors of parents and their willingness to vaccinate their children. So this is something we worked out. We presented this on Research Day. And this was one of the findings. Parents who felt that vaccine safety data is often fabricated had a 0.3 odds, 95% confidence interval, 0.12 to 0.84 of willingness to vaccinate their children. The interpretation is easy. You look at the range, is it odds ratio? Yeah, it's for odds ratio, right? You look at the range, 0.12 to 0.84, ask, does it include the value 1? No, it does not include the value 1, therefore it is significant. You look at the odds, is it less than 1? Yeah, it's a fraction, so that means people who have this factor doing less of something is an inverse relationship. So in this case, what it meant is people who felt that vaccine safety is fabricated, people who feel the companies is make-up thing, were actually less likely to be willing to give their children the vaccine. That's what it means, right? So that's another example for your interpretation, which you can note. Last thing we'll do to conclude EBM part 1 this morning, we'll talk about this thing called p-values. So I think you all would have had a concept of what a p-value is. Maybe, again, I just mentioned the research project. I know some of you all would have done a research project and maybe might have calculated p-values, maybe with the help of somebody else, or maybe you didn't. And in interpreting p-values, people sometimes like to figure out, well, what does thing really mean? What a p-value means? So a p-value, the word p actually means probability. And it's the probability that the findings we observed were due to chance. That is really what it is. That is what a p-value is the probability that the findings were due to chance. Now, what I would say, if we do a research and we say there's a high probability the findings were due to chance, we would say, well, this treatment probably not working. If I did a trial for, what was one of the things they're looking at for COVID-19? They're looking at interferons. So if I did a trial for interferons for COVID-19 hospitalized patients, and I compared it against placebo, and I told you the p-value was 0.9, I'm really saying 0.9 means there's a 90% chance that the findings we got were due to chance. And if there's a 90% probability that the findings we got were due to chance, you would say, well, I don't really care what you find, then this treatment don't really make a difference. I'm not going to give my patients a treatment that produced findings, and the findings you got, there's a 90% probability that it was due to chance. So that in a nutshell really is what a p-value is. But at what level we say, well, I'm going to accept it. It's not so high a probability it was due to chance. 40% probability it was due to chance. 10% probability it was due to chance. We accept as little as only 5% probability it was due to chance. So interpreting a p-value, we want to know if it's less than 5% or more than 5%. Or in other words, if you're mixing up your percentage signs, if it's less than 0.05 or more than 0.05. That's really what we want to know. I'll just give you a little bit of background behind it, but if you missed that explanation I just give, this is the black and white interpretation for p-value. We want to know if it's less than 0.05 or more than 0.05. If it's less than 0.05, what we do? We reject the null hypothesis. Without going into much of statistics, I wouldn't even do this even for the other lecture. The null hypothesis is null. It means there's no difference. The null hypothesis really means there is no difference between the groups. The treatment wasn't better than the placebo. It was the same. So if we reject the null hypothesis, what we actually saying is there was a difference. So if you see a p-value less than 0.05, So less than 0.05, I'll spell it out for the ones who are not too mathematically inclined. Less than 0.05 would be like 0.04, 0.02, 0.01, 0.005. All those numbers are less than 0.05. If you see numbers like that, then you're saying, well, there was a statistical significant difference. Something going on here. There is a significant association. And you have to look at what the p-value is reported for to describe the association. If the p-value is more than 0.05, though, so again, I'll spell it out. If the p-value is 0.1, if it's 0.07, if it's 0.35, if it's 0.9, if it's 0.8, if it's 0.46, all those numbers are more than 0.05, we fail to reject the null hypothesis, meaning we can't say that there were significant differences. There's a high chance the differences was due to chance without being too redundant. So this is the black and white interpretation of a p-value. This is what we're to get. If it's less than 0.05, significant. If it's more than 0.05, not significant. That is the take-home message from the slide. Some students ask, they say, well, what if it's 0.05, the value you get? If it's 0.05, you interpret it actually as the second one. So I should put, if p is more than or equal to, right? I have to look for that character, I'll copy and paste it in the slide. If p-value is more than or equal to 0.05, then we say it's no significant differences, you know? Some people ask, what if it's 0.049? Well, if it's 0.049, strictly speaking, it's significant because 0.049 is less than 0.05. But if you see a 0.049, that definitely is not as significant compared to if you saw 0.01, right? But we try to make it black and white, but as you'll see, or as you probably realize, the real world is far from black and white. We try to make it black and white in the interpretation for simplicity's sake. So let's go into two examples. Again, I try to make relevant examples to what you guys actually, to what the world is going through now. So this was one of the studies that was published in BMJ last month, hydroxychloroquine for patients with COVID-19. And this was the results, copy and paste from the results. So what the results saying? The results saying all kind of stuff. You're reading all this thing about median time to negative conversion. What they mean by negative conversion in this case is that the person got sick, the person deteriorated, right? So the person was ill, they went on to hospital, but then they got more ill. They required ICU care, or the person died, or they got more ill, really. So that was the outcome in this case, the median time to seroconversion. And what I found is, you've seen a whole lot of stuff, but you all know you just have to look at the interpretation, the hazard ratio. Actually, we could interpret this just based on the hazard ratio. The hazard ratio is 0.8. You would say, all right, that may suggest this thing working is less than 1, but we have to look at the confidence interval. The confidence interval is 0.5 to 1.2. That includes 1? Yes, it includes 1, so we know it is not significant. In other words, hydroxychloroquine was not superior, was not better, it was the same as people who got placebo in this study. And here we see a p-value, 0.34. Log-rank test, you don't have to be worried with what that is. You just need to interpret the p-value. P-value 0.034. You ask a simple question. Is that more than 0.05 or less than 0.05? 0.034 is more than 0.05. So it is not statistically significant. The median time to negative conversion in both groups were the same, right? So again, straightforward example. And the other one, the last one I'll talk about was, I just got this from a study that looked at mindfulness-based meditation for generalized anxiety disorder. And they actually gave patients who had anxiety a trial of mindfulness meditation, and they gave a group of people normal standard care. And they found that one of the things that mindfulness-based meditation had on some persons, it increased the chance that they had what we call positive self-statements. So that was one of the outcomes in this study, if people were able to make positive self-statements after they got the treatment. What they found was the p-value for this greater increase in positive self-statements was 0.004. So is the interpretation here? Is 0.004 more than 0.05 or less than 0.05? It is less than 0.05, so means it is significant. It means, in this case, mindfulness-based meditation, what they did was significantly increasing the chance of positive self-statements because the p-value is less than 0.05. right? So that's a very black and white and simple, straightforward interpretation of a p-value. If it's more than 0.05, as in this case, not statistically significant, no significant differences exist. If it's less than 0.04, than 0.05, as in this case 0.004, it means there is a significant difference. Now, again, to interpret p-values, you have to understand what they're comparing. Suppose in this case, we were comparing hydroxychloroquine not with placebo, but with another treatment that we know works. Suppose we were comparing it with another treatment. I don't know what treatment works because generally so far all the studies haven't shown any specific treatment that's actually making COVID patients get much better significantly. So I don't know if one exists to this point. But let's just say for argument's sake, we compare the hydroxychloroquine to a treatment that we knew was effective. We could call it magic drug B, whatever you want to say it is. And we got a p-value of 0.34. In the people who got the effective treatment, we know they got better. If we got a p-value of 0.034, it means the hydroxychloroquine group was no different than the group that got the effective treatment and got better. So it would mean that the hydroxychloroquine group was similar or no different than the group that got better, which would mean the hydroxychloroquine group in that instance, if we did a study like that, the hydroxychloroquine group also benefit in patients. It's also actually working. So anytime you look at a p-value, the interpretation is key. You have to ask yourself, is it significant or not? And then you have to ask yourself, what was the association for? What were the two groups being compared? In this example on the slide, it's very easy because in this case, we know the hydroxychloroquine was compared to placebo. It was a placebo-controlled trial, this trial. So we know it was as good as giving people saline. I think that's what the people got by injection in this group, saline, salt water. So again, interpretation is key, right? So I'll stop here and go to the chat and ask or see what you're seeing. So you all could post the questions. I've seen some posted by Annalise and Justin. So Justin is asking, so anything more than 0.05 or more than 5% is not accepted. Again, anything more than 5%, Justin, is not statistically significant. Again, is how you interpret that statistical significance and what it means. If let me just say we were comparing, I don't know if you remember, the table of baseline characteristics. Remember we say when randomization is done well, it's supposed to produce two groups that are very similar. So when we produce two groups that are very similar, we want the groups to be the same. We don't want them to be different. So actually a p-value of more than 5% is something we want to see in the table of baseline characteristics, right? If we have a p-value for this table, if we had a p-value for age, 66 versus 64 years, and we had a p-value of 0.34, that would actually be a good thing because what it's telling us is the two groups are similar, which is what we want in this example. So to answer your question, it really depends on what the p-value is calculated for and what we did it for and what we're trying to achieve. That is really what it depends. Sometimes we want to prove that differences exist, but sometimes we want to prove that differences do not exist. We actually want to prove that two groups are very, very similar. So it all depends on what we're trying to accomplish. I don't know if that kind of answers your question, Justin. Annalise is asking the question, so if the p-value is less than 0.05, then the data is taken to be trustworthy or significant. I would say yes to significant, Annalise. So if the p-value is less than 0.05, it's significant, but not necessarily trustworthy. I like the way you use that word trustworthy, Annalise, because what determines the trustworthiness of research is not only a p-value. It depends on other factors as well. And I used and alluded to a term earlier on, validity. What you're really asking when you ask if the data or the research is trustworthy, you're actually asking if it's valid. And tomorrow when we go through EBM Part 2, as we wrap up EBM Part 2, we will see what validity is and the things that could influence the validity of research. Sometimes you get research and the p-value is 0.01, statistically significant, but the research have many flaws in it and many threats to validity. And we would actually say, well, although it's significant, it's not trustworthy. So p-values, Annalise, and everyone only tells you if it's statistically significant, which is just one part of research. It doesn't necessarily mean that you could actually go through with it and prescribe the treatment, right? Yelena is asking to explain hazards and odds ratios using an example one more time, please. Definitely, I'd be happy to. So I think the pools, you want me to give an explanation? You want me to use an example using another pool? You all like the pools? The pools kind of, is it helpful? I'll come up with a pool. I'll create a pool, right? So pool, all right, yeah, pool. So let's do a pool. Let me think of an example and give you all one to work out again. Let me see how to do this right. So pools, let me see. Yes, no. Pools are helpful. Yes, Savinda, thanks for that. Let me see. Ratio. All right. Let me see, is this? All right, so look at this one. A study, again, my spelling tends to be off. It's not aspirin or aspirin. I just realized aspirin without a G is aspirin. Yes, it is. So what's the hazards ratio for bleeding with aspirin compared to placebo? The hazard ratio for bleeding for an aspirin compared to placebo was 1.6. So what we're looking at, we're looking at the outcome of aspirin bleeding. And what it should, as a 95% confidence interval, it should read 1.3 to 1.9, right? So it's 1.3 to 1.9, right? So that's the confidence interval. The hazard ratio is 1.6, the 95% confidence interval, 1.3 to 1.9. Apparently in pools, the length of the question you asked, they have character limits on it. So I think that's what happened there. So is it significant? Does aspirin significantly increase your risk of bleeding? Hazard ratio 1.6, confidence limits 1.3 to 1.9. 1.3 to 1.9 as the confidence limits. So again, all you have to do is ask yourself, does the range 1.3 to 1.9 include the value 1? Right? That's all you have to ask. Does the range 1.3 to 1.9 include the value 1? And it does not include the value 1. So because it does not include the value 1, it excludes 1, it is statistically significant. That's exactly what it means. I see some people kind of change their answer back. So they probably changed it to the correct answer, right? So most of you all said, yes, it's significant. So in this example, it means aspirin is significantly increasing your chance of bleeding, right? Because that was the outcome. That is what the hazards ratio was for. Hazards ratio is always a particular outcome. Anytime you say a hazards ratio, a relative risk, a odds ratio, it's always calculated for an outcome. To interpret it, you have to know to interpret the significance or not, but you have to ask, what is it for? In this case, it's for bleeding. So it's for an adverse event. Because it's more than 1, what it means is aspirin significantly increases the risk of bleeding compared to placebo, right? That's exactly what it actually means. All right, so going back to the chat, let me see who's saying what. Pose have a difference in relation, what do they mean? So if it was 0.4, if it was 0.4 Jelani with respect to what the example I just gave, yeah, so if it was 0.4, the value, then you would say, well, aspirin, you're thinking aspirin could decrease the chance of bleeding, but then you have to look at the confidence interval. But you wouldn't have a hazard ratio of 0.4 with a confidence interval of what I had, 1.3 to 1.9, that would never occur because how the confidence intervals are calculated, I know someone always asks me that, how they calculate that, where it come from. They are calculated around the hazard ratio itself. So actually they get the 1.3 to 1.9, they get that from taking the hazard ratio we had of what, 1.6, and saying 1.6 plus or minus something. So what would happen is the value, the ratio you get, the odds ratio, the hazard ratio, relative risk, would always lie within the range of the confidence interval. You would never see a hazard ratio of zero point 0.4, confidence interval 1.3 to 1.9. That would never occur. The ratio you get would always be within the range, right? Right, good. Anything else? Anything else you guys uncertain of or confused about? I know it was a lot. I know the session is intense, even when we do it based in classroom, and there's a lot to digest and take in, but the recordings would be there for everyone to go through with the examples posted, right? And we would also do forums. I know Dr. Khan would have told you all about the forums. I have to assign forums for my topic. I'll try to do that by tonight. And essentially, so I have probably about 9 or 10 forums for my topics that I'm doing today and tomorrow. So by this weekend, everyone would have a forum. 10 people would have a forum, each assigned to them on one of the, based on the stuff that I teach and I do. The other bit for this, so we'll do EBM part 2 tomorrow. The other bit for this, there's an EBM assignment, right, which is an online open book quiz. You'll get that assignment. I'll tell you about it after we complete EBM part 2 tomorrow. And I'll give you all until next week, Sunday, to complete the online quiz. It's an online quiz, open book. You could collaborate, whatever, look at the questions. It's really to test your understanding, but the forums will bring out some of the aspects of what we talk about for clarity. So you probably may want to wait on the forums to see what your colleagues responding and saying and what we're talking about in the forums before you attempt the quiz. I think it helps and clarifies the understanding with this topic, which, you know, sometimes people have a little bit of difficulty with, right? So if any other questions about what we spoke about this morning, right? The next topic we have to do today is basic statistics, which is like about 40 minutes. I want you all to tell me if you all want a break. If you all want a break, I could give you all a break. We could take a 15-minute, half an hour, 10-minute, 20-minute, whatever break time you all prefer or want. Take a cooler, yeah? Yeah, I know I need a break too. I'm tired of talking. Tell me when you all want to come back by. Half an hour. I'm okay with half an hour. I might have to make some calls and respond to some WhatsApp messages. I'm sure everyone have probably messages to respond to. So let's make it let's make it. I'll go in between 15 and 30, guys. Let's make it 20 minutes, right? So we come back at half 11, right? So we'll start back at half 11. We'll start off back on basic statistics. Take a stretch, take a break, grab some snacks. I'll be trying to do the same. I'll see you all at half 11 for basic statistics.